morning, everyone. This is Dr. Khurram Nasir. I am the Division Chief of Cardiovascular Prevention and Wellness at Houston and Methodist DeBakey Heart and Vascular Center. Welcome everyone across the globe live on our Grand Round series. And I just wanted, I'm very delighted to introduce my close friend for the last 18 years, Dr. Matt Budoff, for his Grand Rounds. But before, just a quick message. After the Grand Rounds, you can text your questions live to us at DeBakey to 37607 and online pollev.com/DeBakey. Now, we are extremely honored to have Matt Budoff joining us today for our live Grand Rounds. He is a professor of medicine at David Geffen School of Medicine at UCLA and also an endowed chair of preventive cardiology at Harbor-UCLA Medical Center. His scholarship is, if I keep on going, it's going to take me a day just to highlight that. He has co-authored more than 50 books and more than 1,700 papers and abstract. He is the center for almost all the major NIH studies in this space. And for his work, he has been recognized by the Society of Cardiovascular CT, where he received the Gold Medal Award and recently was designated as the Master of the Society of Cardiac CT and has been inducted in the European Academy of Science. So without taking more time, I'll let Matt take us on a whirlwind tour on the development, the current applications, and the future directions for the exciting times for the cardiac CT. Thank you, Matt, for joining us.
And thank you very much for having me. So today I'm going to take you through, as Dr. Nasir outlined, a little bit of the cardiovascular care. My conflicts of interest are at the bottom of the slide. I have grant support from General Electric. So our outline for today, we're going to start by talking about coronary calcium for the early detection of heart disease to allow for earlier applications of preventive therapies. We're going to talk about faster and less expensive evaluations of acute chest pain, more accurate outpatient testing leading to better outcomes, and finally, how we can combine anatomy and function by use of FFR-CT. So coronary calcium is a very simple test. I know most people are probably familiar with it, but a coronary calcium scan entails a low dose scan of the chest. It's about 0.5 millisieverts with newer equipment. So it's probably about the same as a mammogram as far as radiation exposure. The test takes about 10 seconds to acquire the images, and the entire test for the patient is about 10 minutes. It acquires axial slices through the heart. This is an example of one. You can see the aorta in the center and the left main and LAD going off at about 3 o'clock. If patients have coronary artery calcium, this is what it looks like. Inside the yellow circle, you can see significant amounts of coronary calcified plaque. The computer quantifies these on every slice. So we slice the heart like a loaf of bread from the top to the bottom, and then allowing it to quantify the entire volume of coronary calcification in the heart. The more calcified volume, the higher the Agatston score, the worse the patient is. So it's much like golf, low score wins, and ideally you have no calcified plaque or a score of 0. So calcium is not all of atherosclerosis, of course, but it is the tip of the atherosclerotic iceberg. This is an idea developed initially by Dr. John Rumberger, describing that the concept that calcified plaque makes up about 20% of the total plaque burden, with fibrotic plaque and lipid-rich plaque constituting the rest. And on the right, you can see that's very similar to kind of what we can see when we see an iceberg floating in the water. When the Titanic was going downstream and saw an iceberg, it didn't send divers below the surface to see if there was something that could rip the hull. It knew it was in trouble. The same is true of calcified plaque. If you see calcified plaque, then you know that the patient has more fibrotic and lipid-rich plaque. Not at the individual plaque level, but at the total coronary plaque level, at the patient level. So this was one of the most important papers that have been published in the realm of coronary calcium. We had a lot of observational data that supported this, but this was a prospective population-based study from the National Institutes of Health called MESA, Multi-Ethnic Study of Atherosclerosis. And this demonstrated if you had a score of 0, you had a remarkably low risk of events. And as the calcium score went up, your risk of cardiovascular events went up proportionally. By the time your score was over 100, so think of maybe a volume of 100, you had a 10-fold increased risk of non-fatal MI or cardiac death. So the best application has been shown in intermediate risk. So this is another population-based study called the Heinz-Nixdorf recall study. The shaded area in yellow is patients who are identified at 10 to 20% risk. So they start out at intermediate risk. If you do a calcium score, you upregulate or you increase the risk appropriately in 14% of patients. So 1 out of 7 of these intermediate risk patients will have a high calcium score, becoming high risk, and a vast majority of patients will have a 0 score, implying very low risk. And this is net reclassification, and it is the best of any available test we know of in primary prevention. There is no test that outperforms a calcium score to classify risk. But I want to emphasize that a lot of these patients, more than half of patients from the intermediate risk category, actually get D risk. They go to a score of 0, and we'll discuss that, but that's a very important concept that most patients in this category have lower risk than we originally thought. There is randomized trial data available for calcium scoring. This is the St. Francis randomized trial. It was a study done quite a while ago, but was most likely the last of these types of trials because it's now considered unethical to randomize patients with calcified plaque to statin. But they did just that. They took patients, took a little more than 1,000 patients and randomized them to no prior CVD and a calcium score above 80%, and they randomized them to atorvastatin 20 or placebo and followed them for subsequent events over the next 4 years. Patients who were randomized to atorvastatin with established calcified plaque had a 30% event reduction, and event rates were more significantly reduced in participants with baseline calcium scores above 400, where there was a 42% reduction. So importantly, the higher the calcium score, the bigger the benefit from atorvastatin 20 milligrams. We talked a little bit about the power of 0 as a negative factor, but what you can see here is that as the calcium score goes down, you can see as with a low calcium score, you can see a very low risk. So those patients with calcium scores below 10 or 0 had the lowest long-term risk. You compare it to other low-risk states, and they had more events. This is a paper I published with Dr. Nasir and others by Mike Mortensen and Jack. But if they had no carotid plaque, they were at higher risk. If they had a low CRP, they were at even higher risk. If they had a low Lp(a), they were at fairly high risk. So here we can see that a picture is worth 1,000 words. This is the motivational effects of coronary calcium scores. And basically, the concept here is that patients who have a high calcium score have a very high risk of cardiovascular events, and therefore are motivated to behave better. So we showed over 4 years that patients were more likely to be adherent to statins and to lose weight. Other studies have shown better initiation of statins, aspirin, and blood pressure therapies in patients with a positive score as compared to those with a score of 0. Calcium has been incorporated in the guidelines in 2018. These are the ACC-AHA National Cholesterol Guidelines. And you can see that it got a 2A recommendation for intermediate or selected borderline risk adults. Use of a calcium score in the decision to withhold, postpone, or initiate statin therapy. So that's important because that's 5% 10-year risk all the way up to 20% 10-year risk, a very broad category where calcium scoring is now a 2A recommendation. And at the bottom box, you can see if the calcium score is 0, it is reasonable to withhold statin therapy and reassess in 5 to 10 years. If calcium score is greater than 100, it is reasonable to initiate statin therapy. So you can make prudent decisions about your individual patient, individualized or personalized medicine by knowing the coronary calcium score. That was best validated in this large observational study from Walter Reed. You can see in the upper left box, those patients with a calcium score of 0 and the very low event rates. And in the lower left box, what happens to those patients with a score of 101 to 400. Now, there are 2 lines in that lower left box. So you can see the red line represents a population that had been on statins for the entire duration. And the blue line represents patients who were not on a statin for the entire duration. And you can see a 68% event reduction over 10 years. Number needed to treat of 12 patients on a statin if their score is above 100. Compare that to the upper left box, patients with a calcium score of 0. There are actually 2 lines there, a red line and a blue line, even though you can't see the difference between them. So taking patients and putting them with a calcium score of 0 on a statin lowered events by 0%, hazard ratio 1.00, and the number needed to treat for a score of 0 would be infinity. No patients had less events if they were on statins for a decade with a score of 0 as compared to no statin and not being with a score of 0. That upper left-hand box represents over 8,000 patients, over 9,300 patients. So a huge population of patients being observed, not randomized data, but with no benefit for long-term statins with a score of 0. And I think this came out after the guidelines, but I think validates the concept that in this upper left group, score of 0, you can forego statins for at least 5 years. There's no clinical benefit that we can establish. And in the bottom box, patients with scores above 100, we should initiate statins because there's a large reduction of risk. We can get the same type of data with aspirin. This is another paper that we co-authored with Dr. Nasir, also out of MESA. This is Mike Medema's work. And you can see that red line represents number needed to harm. That's the GI bleed risk. And if they had a calcium score of 0, whether they were low risk in blue or high risk in red, the number needed to treat is higher than the number needed to harm, implying that you are going to be harming more patients than helping if you take patients with a score of 0 and initiate aspirin therapy. Now look at the far right, calcium score greater than 100. You can see whether they're low risk or high risk by Framingham, the number needed to treat is far lower than the number needed to harm. And for every 5 MIs you would prevent, you may cause 1 GI bleed with aspirin. So in general, I initiate aspirin therapy in my primary prevention patients with elevated calcium scores, and I forego aspirin therapy in those with scores of 0 because they're going to have a higher likelihood of GI bleed than benefit from the aspirin therapy. So let's go on to CT angiography. I think that is the place that's garnered a lot of interest because cardiologists like to look at our arteries and like to see percent stenosis, and we do not derive that information from coronary calcium scores. CT angiography is a very simple test. Thin slices, single breath hold, usually about 15 seconds, 50 to 60 cc's of non-ionic contrast. It is still iodinated, so we have to be cautious about renal insufficiency and iodine allergies, but it's about a 20-minute procedure and maybe a 10 to 15-minute interpretation. The large number of studies are too great for us to go through, but I want to just point out those studies in red, circled in red. And you can see the negative predictive value. In other words, if you have a CT angiogram that shows less than 50% stenosis or normal coronaries, the likelihood that they have no significant stenosis is 99%. So going on and working them up for angina, going on and working them up or doing a cardiac cath when the CT angio failed to show a stenosis will have a yield in the cath lab of 1% or less. So this is an excellent way to assess the front end of the cath lab. The lower probability patients get a negative result or a less than 50% stenosis result and get them out of the system. It works really well in multiple conditions such as valve disease and in heart failure. Patients with heart failure, this was a study by Daniele Andrini in Italy. He looked at the diagnostic accuracy of CT angiography in patients with heart failure of unknown etiology. And he showed a negative predictive value of 99.8%. So this is a really excellent way of discerning whether somebody with congestive heart failure has an ischemic cardiomyopathy or a non-ischemic etiology. In the patients who underwent CT, there were no complications. Those that underwent conventional angiography, there were 10 complications. So of course, non-invasive CT requiring just an intravenous access is safer than conventional angiography with a p-value of 0.001. So another place that it works really well is in the emergency department. As I outlined in my original introduction, there are now multiple studies demonstrating that CT angiography affords a faster and less expensive algorithm. It's been studied against multiple different modalities. This is the ROMACAT study published in the New England Journal of Medicine by Udo Hoffman. And you can see here in red is the standard emergency department evaluation. So they're randomized to standard of care in the emergency department across multiple emergency departments on the East Coast, or they were told to get a CT angiogram. You can see the line at 12 hours. At 12 hours, 21% of patients were discharged in the standard evaluation as compared to 62% at 12 hours by the CT angiography group. So discharges were 3 times higher at the 12-hour mark. The median time of discharge is listed there, 8.6 hours for CT angiography, 28.8 hours for standard emergency department evaluation. There have been a total of 6 randomized trials of CT angiography as compared to in the emergency department as compared to other modalities. And it is faster and less expensive than nuclear in 2 trials, exercise treadmill in 1 trial, standard of care in 2 trials. And in the last trial, the Beacon study, CT angiography, was compared to high sensitivity troponins, and it was similar in time to discharge, but it was 34% less expensive for healthcare to get a CT angiography in the emergency department than to just discharge them after 2 troponins. And the reason was at follow-up, there was a lot of follow-up in those patients with negative troponins because that did not resolve whether the patient had cardiac chest pain or not, just whether they were having an acute MI. And once you had a negative CT angiography, we had the answer that their chest pain was non-cardiac. So it resulted in less follow-up and much less cost to do a CT angiography in the emergency department, even than low sensitivity troponins. And that was the Beacon trial. So that led to incorporation in the 2014 guidelines. This is the US non-ST elevation guidelines, ACC/AHA guidelines. And basically they said that coronary CT angiography is associated with rapid assessment, high negative predictive value, decreased length of stay, and reduced costs, and gave it a class 2A recommendation. in patients with possible acute coronary syndrome and a normal ECG, normal cardiac troponins, and no history of coronary disease, it's reasonable to initially perform cardiac CT angiography to assess the coronary anatomy. So as a frontline test, a class 2A recommendation. The radiation dose of cardiac CT has dropped dramatically over the past decade. Now we can see doses for calcium score, as I mentioned, of 0.5 millisieverts, which may be similar to or maybe even lower than mammography. But the original 64-slice CT angiogram studies were in the 9 millisievert range. So background radiation is about 2 to 3 millisieverts per year. So that's about 4 years of exposure. But with our newer scanners, faster scanners and better techniques, we can now get those doses down with prospective imaging, even with the 64-slice scanner, if careful protocols are followed, down below 3 millisieverts per year or below background radiation. So the doses have come down quite a bit. If we compare that 3 millisieverts or 2 millisievert dose to coronary angiography, averages about 8 millisieverts, and nuclear imaging is 9 to 41 millisieverts, depending on the protocol used. So technetium studies. So you can see a wide array of potential doses, but dramatic improvement in radiation exposure to our patients with CT angiography over the past decade. With the newest equipment, the most recent CT scanners now and the newest dose reduction modalities, we can get images such as this. You can see beautiful coronaries, make 3D models, make angiography-like images, and look at plaque assessment on the far right. And you can see a non-obstructive lesion. The yellow on the far right image represents the calcified plaque, and the pink represents the non-calcified plaque. And you can see a mild mixed plaque with no obstructive disease for a total of 0.6 millisieverts of radiation. So this has been compared or been discussed as supplanting invasive angiography. So we want to understand how that can happen. As replacing functional testing. So we want to understand, why would we move away from functional testing? We have such great data and such great experience with things like SPECT and stress echo and treadmill and even cardiac MR to assess ischemia. Why would we move away from ischemic testing? And I think the biggest reason, this was published from the National Cardiovascular Data Registry, or the NCDR, representing over 385,000 patients who underwent invasive angiography at 1,100 hospitals. So these are patients who underwent cardiac cath because of and had a functional test as their reason for being indicated. And you can see that of the patients who were referred from SPECT, only 45% were found to have obstructive disease, 55% false positive rate. They had no obstructive disease during invasive angiography. Same was true for stress echo, treadmill testing, and cardiac MR. All of functional testing led to only a positivity rate of 45% and a false positive rate of 55%. So this is what's been pushing us to consider, if we want to use cardiac cath and effectively to do it by understanding that anatomy, and CT angiography may provide a better surrogate for what we're going to find in the cath lab as compared to referring from a functional test. The Avinci study took the same patients and had them undergo different tests. On the far left, you can see the diagnostic accuracy of CT angiography. And I want to point out that this was an exceptional study because a true positive or true negative was based on either a 70% stenosis in invasive angiography or a positive FFR, invasive FFR. So they had to have one of those two to be a true positive. And you can see Sensitivity and specificity of CT angiography was over 90%. PET was close, but SPECT, cardiac MR, and stress echo, all diagnostic accuracy fell off to the 70% range. So we go from over 90% sensitive and specific to an average of 70% accurate when we incorporate things like SPECT or stress echo to assess for obstructive, highly obstructive disease or positive FFR patients. This pathway has also been demonstrated to improve outcomes. The Scott-Hart trial had 5-year follow-up in a large cohort of patients. And you can see the blue line represents outcomes in the CT angio group, the group randomized to CT angiography. So this was a randomized prospective study over 4,000 patients, randomized between CT angio or standard of care. Standard of care was functional testing. And you can see 41% lower death rate and lower MI rate in the cardiac CT group than in the standard of care group. This, of course, was highly statistically significant, demonstrating that it was better to stratify them to CT and have CT as the frontline test for diagnosis and treatment. That was emulated in the subgroup of the PROMISE trial. The PROMISE trial was more neutral. It only showed a 25% reduction in myocardial infarction in the CT group as compared to the functional group, which was not statistically significant in the overall trial. But follow-up in the PROMISE trial was truncated at 12 months in a majority of patients. They were initially going to have longer follow-up, but ran out of money as part of the study. But if we look at those higher risk patients in the PROMISE trial, a randomized trial of CT angiography, this time CT angio in red, and functional testing in blue, you can see a very similar separation of curves. There's about a 50% event reduction in the patients who underwent CT as compared to those who underwent functional testing. So both studies were concordant. The PROMISE trial didn't have as long a follow-up in their cohort and didn't show statistical difference at the overall analysis with only a 25% reduction in MI in the CT group. But when you look at the higher risk cohort, such as the PROMISE diabetic cohort, you can see a similar curve separation to the Scott-Hart trial. If we look at 3 randomized trials and pool them together, this was a meta-analysis done by Dr. Bittencourt, and you can see a 31% reduction if patients underwent CT angiography. This is for myocardial infarction, 31% reduction in MI if patients underwent a CT first as compared to a functional test first. So the guidelines in the US and around the world are starting to change. This is from the United Kingdom. In the United Kingdom, you can see in 2016, this is their update and what they've been doing in the United Kingdom since 2016. And you can see for those patients with atypical angina or typical angina, here in the lower right box, refer directly for diagnostic imaging. And diagnostic testing as of 2016 is 64 slice or above cardiac CT angiography for all patients. CT angiography for all patients. Functional imaging if CT angiography is non-diagnostic or if diagnosis is uncertain in patients with established coronary disease. So functional testing is a backup if we need to understand the CT angio results better. In our lab, if we have an equivocal stenosis, we might consider functional testing as a backup if it's 50 to 70%, although I'm going to discuss FFR-CT as another option in a moment. Or if patients have a non-diagnostic CT, too much coronary calcium, motion, suboptimal images, then we typically recommend a functional test. The European guidelines came out last year and basically emulated that. They said for patients with low probability on the left, low probability of disease, less than 50% probability, coronary CT is preferred. If they're higher probability, above 50%, testing for ischemia, imaging testing is preferred. And for those with very high pretest probabilities in yellow, invasive angiography is preserved with either FFR or other flow reserve calculations. So the choice of test is based on obviously the likelihood of characteristics, patient characteristics, and the clinical likelihood of disease. But CT angiography is now recommended in a vast majority of patients because most patients who present to our primary care and cardiology offices are in that lower risk group. The ischemia trial, obviously looking at whether or not we should be stenting these patients, did have a nice demonstration of how ischemia was suboptimal and CT angio stratified risk better. In the ischemia trial, everybody got a CT angiography before enrollment, and everybody had a functional test before enrollment. So just looking at the performance of functional testing, we can see that those patients with no or mild ischemia, whether they were randomized to invasive or conservative management, had more events than those patients who had severe ischemia. Hard to explain, but ischemia testing did not stratify risk well. The more severe the ischemia, the better the patients did, even in the conservative or invasive management. So it did not stratify risk properly. Those with less ischemia had more events. Look at the far right. You can see a near perfect stratification. Those patients with single vessel disease had the lowest risk of future events. Those patients with two vessel disease in orange had more events. And those patients who had multi-vessel disease by CT angiography had by far the highest events with a p-value less than 0.001. So CT angiography, even in the most recent ischemia trial, was a much better stratification tool for who was going to have events over time, whether we treat them invasively or conservatively. So we can match intensity of risk with intensity of therapy much better with a CT than with a functional test. So, and they concluded, this was David Marin presented this at ACC virtually in 2020. He concluded that anatomy was more predictive of outcomes than ischemia. In those patients with site-determined moderate or severe ischemia, there was no association with ischemia severity and death. And there was a strong association between the extent and severity of CAD and risk of death in MI with CT angiography. So if we now go on to trying to match ischemia with anatomy, if we try to pair the ability to look at anatomy, we have two ways of doing this with CT. One is FFR-CT on the left. We can do modeling, and I'll describe that a little bit better in a moment. We can do modeling to determine the approximate flow and really approximate invasive FFR with excellent accuracy. And the FFR-CT creates a model and gives us a estimated FFR. At any point in the coronary tree, you can move that black arrow up and down and get different levels of FFR models for that vessel. On the right is perfusion imaging. Perfusion imaging requires a second scan and a second bolus of contrast with a perfusion agent. So it's not used very much because it would double the radiation exposure and increase the contrast dose, whereas FFR-CT is post-processing of the original CT image. So as we think about anatomical testing on the left, and we see a funny stenosis, possibly severe stenosis on the in that LAD, and then we think about the data that we get from functional testing, and we can see ischemia or ST depression or decreased flow to the myocardium. There's now the possibility of combining the two, of taking that anatomical test, applying FFR-CT modeling, and determining whether or not you have ischemia or decreased flow to certain distributions of the coronary bed. That has been studied in multiple trials. There have been 4 prospective trials of FFR-CT. The largest was the NXT trial, and basically demonstrated, if you look at blue, the diagnostic accuracy of CT compared to invasive FFR. So it's highly sensitive, but not very specific. In other words, with cardiac CT by itself, we overcall stenosis. If you look at the improvement, when you add FFR-CT, if we look at the overall accuracy, it goes from 53% to 81%. Again, with invasive FFR, multi-vessel FFR is the gold standard, and specificity goes up dramatically by use of FFR-CT in addition to cardiac CT imaging. If we think about the benefits of adding FFR-CT, overall, if we just took patients to the cath lab, there would be 32% positive rate. If we look at large cohorts of patients who end up getting revascularized in both the platform and advanced studies, those numbers went up to 72 and 73% respectively. So we can be much better at guiding revascularization by adding FFR-CT to CT angiography. The normal rate, the rates of normal cardiac cath or non-obstructive disease, dropped to 12% from about 70% without FFR-CT. It dropped to 12%. So we get more revascularizations and less normal caths if we add FFR-CT as compared to either standard of care imaging, functional testing, or CT angiography alone. If we look at the Pacific trial, this is a trial that looked at PET, SPECT, coronary CT. You can see SPECT, as I mentioned before, had a fairly low accuracy. In orange, 70% was the area under the curve, representing poor performance. PET and in green and cardiac CT did much better. And you can see improvements. So with an area under the curve of 0.83 for CT and 0.87 for PET. But when you added FFR-CT with the heart flow analysis to the CT images, you achieved the blue line, which is an area under the curve of 0.94, by far the most accurate to determine the presence of significant lesions when these patients were taken to the cath lab. It's not that we should be testing patients with severe stenosis. This is a large registry called Advance. If you look at the far right, those patients with severe disease on CT angiography obviously had a vast majority of blue. Blue represents patients with a positive FFR-CT or an FFR-CT of less than 0.8. When we get to the 70 to 90% stenosis, obviously, we eliminate the red, the patients who we don't need invasive angiography because they do not have functional ischemia. And the biggest benefit are in those patients in the 50 to 70% range, where you can see equipoise here. Many of the patients who had 50 to 70% stenosis by CT angiography did, over 1,000 of them out of 1,600 did have a positive FFR-CT, less than 0.8. But 600, about 40% of them had a negative FFR-CT. And there was even nice benefit in the 30 to 50% stenosis group, where a little less than half did have a positive FFR-CT. So in our lab, we use it selectively in the 30 to 50% range when patients have CT angiography and they may or may not have a significant stenosis. Some of those cases are harder to read because they have increased calcification or multiple lesions. And then we use it a lot in the 50 to 70% range, where we have pretty good equipoise of whether or not they're going to have significant ischemia and would benefit from invasive angiography and revascularization. So here's our target group in general. If we looked at the advanced registry, they had 90-day follow-up. They now have longer follow-up as well. And you can see at 90 days, those patients with FFR-CT greater than 0.8 had a virtual 0 event rate. And those patients with FFR-CT below 0.8 had a significant event rate. They were 20 times more likely to suffer a cardiovascular event, a MESA event, with a p-value of 0.001. And even for death and MI, the heart events on the right, 15-fold increased risk if their FFR-CT was less than 0.8, with a p-value of 0.0077. So I think where we are today, and I'll finish up so we have some time for questions, is that we can identify normal patients with 99% negative predictive value. So we can eliminate those patients who are deemed to have low risk. We can, with both coronary calcium and CT angiography, we can determine who needs preventive medical therapy. Again, in the primary prevention realm, we use coronary calcium scanning. In the patients who are symptomatic, we use CT angiography. But in both the PROMISE trial, the SCOT-HEART trial, and the CAP trial, those patients who underwent CT angiography got more preventive therapies than those patients who underwent functional testing. Because you might say, okay, they don't have obstructive disease, but I found a 30% stenosis. I better put them on some statins, aspirins, et cetera. It's a much more efficient triage for reducing downstream testing and revascularization. And now with the ability to add FFR-CT, we can be even more efficient and reduce our normal cath rate while improving revascularization rates in our cath labs. The ISCHEMIA trial taught us that it's useful for identification of left main stenosis, something that we're not as good at with functional testing. So another potential advantage over functional testing as the first line test. And we know that it's excellent for patients with low to intermediate risk of acute coronary syndromes compared to the current standard of care, with 6 positive randomized trials showing CT angiography is superior. It's been endorsed by multiple payors and recently covered by large RBMs such as Anthem has now changed their coverage decision and now covers cardiac CT and coronary calcium. Don'ts with cardiac CT: patients who have severe calcification don't get a CT angio. Calcium scores above 1,000 become really hard to interpret. So in general, we try to avoid those patients. And if necessary, that would be a good place to do a functional test. Stents are fine, but if you have multiple stents or stents smaller than 2.5 millimeter diameter, CT angiography is suboptimal. If we can't control the heart rate, we can't do the CT angio. We do need to freeze cardiac motion to take pictures with CT angiography, and we typically use beta blockers or calcium channel blockers. But if we cannot achieve a heart rate control, we typically have to forego the test. If they have a very high pretest probability of coronary disease, I would advocate, like the European guidelines, to still go straight to the cath lab. I think that's most prudent, rather than giving them a dose of contrast and a radiation with CT, and then having to follow it up with a dose of contrast and radiation in the cath lab. And finally, renal insufficiency and contrast allergies we have to be cautious with. So we can continue to do what we've been doing, a lot of functional testing. This is one of my patients had a normal functional test. I reassured him. He had some symptomatic, some atypical symptoms after the nuke. I was not comfortable. He had multiple risk factors. So I did a CT angio, found a large plaque in the proximal LID. In this case, FFR-CT was negative, so I did not revascularize him, but we instituted statins, aspirin, lifestyle changes, and he now knows he does have disease, whereas the conclusion from the nuclear test was he doesn't have disease. And I think that's a huge difference for our patients, and it really motivates behavior much differently, and it changes my behavior much more when I see the anatomy rather than try to infer the anatomy from a functional test. The Warrior trial is an ongoing study. We're going to be looking at women who have a abnormal less than 50% stenosis by CT or cath, and randomize them to optimal medical therapy or standard of care. And if anybody's interested in participating as a site, we're still looking for sites. Please send me an email. And finally, I'll leave you with this conclusion. This is from Arthur Schopenhauer. All truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. Third, it's accepted as being self-evident. And I think that this is where we've been with cardiac CT. And I think I can finally say with some confidence that we're coming out the far side, and we're accepting as being self-evident that seeing the anatomy with cardiac CT will be better than inferring the anatomy with functional testing. And we're starting to see a big shift in practices as CT angiography becomes more accepted and expertise continues to improve. So thank you very much for joining me, and I'll be glad to answer any questions.
Hi, Matt. Thank you so much for this wonderful talk. I truly enjoyed understanding this whole process of the development, the current applications, and the future directions. And it was an honor working with you in this journey over the last 18 years. And as you pointed out, that we have come through different stages now where it is the evidence is self-evident. But how would you respond to some criticisms that would come in that we still don't have an outcomes trial for calcium scores like mammogram? And is there a role yet, in spite of the fact that it's hard to randomize those with high calcium? Do you see an application maybe moving to the younger population?
Yeah, so we've gone to the National Institutes of Health 3 times asking for a large randomized trial like the lung cancer screening trials. Or some of the mammography trials, and they don't want to fund it. They feel that it would be, too big a group to tackle and maybe unethical to randomize patients with high calcium scores to no statin. So I think that that's part of our problem. I think that we have to look at the robust data that we already have. The guidelines now advocate for calcium scoring, and it's a simple test. I mean, to add it on to your algorithm of care is so simple, and in most centers, very inexpensive. And we're starting to see payers come around to covering it. Anthem just announced a positive pay as of January 1st, where they're covering calcium scoring for the low to intermediate risk patients, asymptomatic. So I think we can use the test either as an out-of-pocket expense or as a covered expense. And yeah, you're right. The younger they are, age under 40, I get nervous. I don't like to scan patients under calcium scores under the age of 40 too much because they might have a false negative. But I think 40 to 75, our cholesterol target range is robust with calcium scoring.
Okay. So Matt, a few questions coming in from the audience, very exciting. One is that while you highlighted the value of doing a CT angiogram in symptomatic patients, of course, identifying the disease and maybe better triage, but what's your experience in the real world where we are seeing potentially more revascularization rates are slightly higher in individuals who are randomized or who undergo CT angiogram as a first diagnostic test as compared to maybe a functional testing?
Yeah, so in the Scott-Hart trial, there was actually more revascularization early on, but by the 5-year follow-up, the revascularization rates were identical between those randomized to functional testing or CT angiography. They just got delayed revascularization. So I'd say for those people who feel that revascularization is overdone, we have both the PROMISE trial and the Scott-Hart trial that show early on we do more invasive testing, but that results in a lower MI rate. And in the Scott-Hart trial with near perfect follow-up in over 5 years, there was no difference at all in revascularization rates. So I think that that's just shifting the revascularizations a little bit earlier, capturing them before they have the MI, rather than cathing them and performing a revascularization after the MI. if we delay that. So I don't think it really increases revascularization rates. I think it just shifts it a little bit earlier, where we can do more good early on if we can identify patients with left main or severe 3-vessel disease.
Right. So now just moving the discussion to maybe applications in CABG. So a question that came in is, in your view, what is there a place for CT angiography for appreciating the wall of the mammary artery before CABG? Have you ever, is there any discussions around those issues?
Yeah, there's actually an incredible randomized trial done in Europe where they randomized pre-CABG patients to CT angiography or a placebo, and it actually dropped the stroke rate by 60%. 60% less strokes in patients who underwent CT angiography instead of no CT angiography prior to CABG. So that is not only looking at the mammary artery and seeing where it is, maybe looking at the, if any, if they're pre-existing grafts, if they're close to the sternum, but more importantly, looking at the aortic wall. And if there's a lot of plaque in the aortic wall, they could change their approach. So I think that there is great value in CT angiography prior to CABG. And actually, probably the best outcome study we have in all of cardiac CT is pre-CABG. So if you want to go with the evidence, before every bypass surgery, you should do a CT angiography. And if any people email me, I'll send them that randomized trial data from Europe.
That is fantastic insight, Matt. I didn't realize that, but I would love to review it. So now getting to a little bit more technical, for calcium scores, is it appropriate to utilize, or have you tried any newer scanning modality, especially the flash as compared to axial acquisition protocols to lower the dose?
For calcium scoring?
Yes.
Yes, I haven't done a lot with looking at the different acquisitions of calcium scoring. Obviously, the scanners continue to evolve, and there's better and faster ways of doing calcium scoring at even lower doses. But I would argue that 0.5 millisieverts, which is our average with prospective triggering, is already very low. It's a couple months of exposure in real life. So if you're 60 years old, you might have gotten 200 millisieverts of background radiation. If you're 60 years old and got a calcium score, you've gotten 200.5 of millisieverts of exposure. I just can't imagine that that's what tipped you over to cancer. So I think there are some interesting new applications, and we will get that dose even on calcium scoring lower and lower. But I think that's probably less. It takes away some of the criticism of doing mass screening. So I think it's important, but I think for the individual, it's not that critical.
So Matt, now moving to FFR-CT, yeah, one of the dilemmas that we see, it's interesting, although it does provide significant insights and discrimination when you have significant stenosis, heavy calcified plaques, but also as in advance, we also see that those with 0 to 30% stenosis, still about 60% showed a positive FFR-CT rate. So what's your thoughts on that? Should we even do FFR-CT if you have a lesion that's less than 50% because of these potentially false positive? Are they false positive? How do you view them?
Right. So I think, if you talk about the 30 to 50% stenoses, I think that these are selectively chosen too in the registry. So I want to point out that there's many patients who have barely a 30% stenosis, a little bit of soft plaque. I would never get an FFR-CT on. In the advanced registry, we selectively used FFR-CT. So I think those are more of the dense calcified plaques or the multiple 30 to 50% stenoses, and then they were found to have severe ischemia in one of the distributions. So I think that it's prudent. I think you have to just select your patients from among those people with less than 50%. But I do think it helps a lot in selective cases at 30 to 50. And I use it almost exclusively in all of my patients who I can with 50 to 70% stenoses to help sort out, is that 50% lesion ischemic, or is that 50% lesion not going to cause trouble and I can just treat it medically with more confidence?
Right. So now that we have seen that the data is extremely reproducible from clinical trials, the issue is in the real world, we are going to have a lot of non-academic community-based practices where cardiac CTs are read, less experienced interpreters. So do you see, what's the path forward? Do you see maybe a solution having more automatized machine learning, AI-based reading that can do that? Or how would you see the discrepancy that may happen when, especially when inexperienced interpreters are reading those CTs with a high risk of chances of calling them falsely positive?
Yeah, I mean, I would hope that, whether we go towards AI, which I think is a little premature so far, but maybe the future, I think it's going to take a while for the computers to figure out, severe stenoses and put all of these things into context, but it's possible. I think now, though, we can use teleradiology. We can, hopefully less experienced readers can refer these patients or send the images to a more experienced reader. I get some reads from around the country and around the world, selective cases where people want my opinion of the CT angiogram. So I think we can at least use teleradiology right now to interpret these. And I would hope that if somebody's not comfortable with the interpretation, a less experienced reader sees a case with motion or a lot of calcium, not that clear what's going on, that they can ask for some help. Or we use centralized reading centers. We develop experts around the country, around the world, that are really expert at reading CT and let them read a majority of these. There is an interpretation learning curve that's pretty steep, and it does take a while to get to become a good reader for CT angiography, just like I think it takes a while to become a really good interventionalist in the cath lab. I don't think, we always want the least experienced person being the front line for every test. If it's normal, anybody should be able to read that without too much issue.
So a couple of questions that's coming to my mind on my own personal interest. Of course, we have now seen CT angiogram as an established tool in the choices that we have for risk stratifying patients coming with acute chest pain or even stable chest pain. But Matt, even to date, we see that almost about 50% of those CT angiograms are completely normal. And you and I have always discussed a lot that, is there a pathway forward? Do you see a pathway forward for calcium testing to act as a gatekeeper, something like the Confirm did? But because as we are moving towards value-based care, can we do better in reducing the likelihood that we'll see almost 50% of the CT angiograms being normal? What are the barriers? What can we do to address that?
Yeah, so, I think a calcium score of 0 is an excellent tool. I think that for acute chest pain, I would be a little bit leery, and I think that's why the United Kingdom started there. They said calcium score first, and then if it's positive, go to CT angiography. I think in acute chest pain, you could have spasm, you could have other things going on. So I think in the emergency department, it's probably in the long run more prudent, if possible, to do a CT angio. But I think for stable chest pain, if you have a score of 0, especially over the age of 40, I'm very comfortable saying that they have such a low yield on CT angio that I could stop at the score of 0. And we do that for our firefighters. We take care of 6,000 firefighters in LA City and LA County. And if they have a score of 0, they are done with their workup.
So Matt, what can we do to convince our guidelines that still continue to caution in the stable chest pain? And some of the guidelines have even given a class 3 recommendation in these areas, in spite of the wealth of data that has come across the globe, especially from your group. How can we convince the guidelines?
I think we need to publish more on what happens in symptomatic populations with a calcium score of 0. I published the PROMISE trial. We had PROMISE was randomized CT angio versus functional testing. I looked at the calcium scores versus functional testing, and calcium scores outperformed functional testing in the PROMISE trial, and those were symptomatic patients, granted low risk symptomatic patients, but I think that answers the question directly. I think we can even look maybe at the ISCHEMIA trial data and look at the calcium scores and show that it's a really good risk stratifier. Because remember, you're trying to predict who's going to have an event, not who's going to have a 50% blockage. Our goal has to be to lower events, not to just find disease. We know that now from Courage and ISCHEMIA. So I think the important answer is going to be scores of 0, even in symptomatic patients, are safe. They are low risk and can be treated medically. And if we can get that message out, looking at risk rather than percent stenosis, I think we're going to be able to convince the powers that be.
Well, Matt, I love the title of your recent editorial, The Power of Zero is Stronger Than Soft Plaque. So that was wonderful. So coming to soft plaque, and now that with CT angiogram, we have an ability not only to look at soft plaque, but now go into more details to assess features that in the past we considered as high risk. For example, soft Tunisian plaque, remodeling, microcalcification, ring signs. Now, how would you consider where would that fit in the logarithm of risk assessment, considering that we looked at the Scott trial and although it predicted events, but once you account your burden by calcium score, the value wasn't there. So in 2020, where would you assess and how would you use those signs?
So I'm still not a firm believer in the vulnerable plaque and the ability for us to fix an individual plaque. I'm still interested in the vulnerable patient. I want to identify the patient who needs more aggressive care. And therefore, I think a global atherosclerosis score, like a calcium score, or maybe if we could quantify plaque on a CT angio better and get a total plaque burden, I think that that's going to be a better predictor than these individual lesions that look scary. We know that from the prospect trial with the invasive data as well, that it may be futile to go after the vulnerable plaque. So I'm still a believer in just trying to identify patients at risk rather than lesions at risk. Because when I give a statin, I can't give it to just the mid-LAD. I have to give it to the whole patient. So I'm still interested in that. And remember, statins induce stroke reduction as well, which I never imaged. So it goes to other vascular beds that we're not even seeing. So I think we need to focus on the vulnerable patient more than the vulnerable plaque.
Pearls of wisdom there, Matt, focusing on the vulnerable patients. So one of the questions came in that the local data, usually, of course, everybody's trying heart flow these days, is that most of the patients that heart flow is being used is among much lower risk than what was in the platform trial. And that really changes the cost effectiveness and utility. And so what's your take on the real world revascularization rates in the real world who get CT as a first test? And you see by adding FFR, potentially we can selectively reduce the numbers of individuals going for revascularization, which is one of the downstream impact that we see with CT as a first test.
Yeah, no, I think if you look at and I showed it briefly, but I was trying to cover a lot today. But if you look at the platform study, which was a randomized trial using CT in a selected population, it did really well. It reduced the FFR-CT, reduced normalcy rates, and improved revascularization targets. If you then compare that to the advanced registry, which is a real world registry, it did exactly the same. The numbers were 72% revascularized in platform after FFR-CT, 73% revascularized after FFR-CT in advance. So I would argue that the real world data emulated the platform study perfectly. Now, you broaden it to larger cohorts and bigger populations. Obviously, we need to continue to do research, but I have to say, and totally independent of anything I do with my research, and I don't get grant support from HeartFlow, but if you look at the data that they've put out, and they have a lot of data there, this is performing really well in the real world. And I would encourage people to look at that advanced registry and from around the world and see how well it performs.
Well, Matt, this has been a fantastic conversation, and I'm just going to finish with one comment and one question from Dr. Bill Zogby. He sent his congratulations. This was wonderful. But at the same time, you have taken us and you have been pivotal in the journey over the last 20 years where we have truly gotten calcium testing and at least the CT angiogram within the guidelines in the real world practices. But now, what can we do truly to get it as a class 1 indication for risk assessment? What are the two things that would take us from a class 2A to a class 1 indication for calcium, as well as the CT angiogram for chest pain in the next 5 years? Pearls of wisdom, give us your final thoughts on that.
Well, I think it has to already be a class 1 for CT angiography, especially in acute chest pain. We have 6 randomized trials. A class 1 indication requires 2 randomized trials. So I can't imagine anything more that needs to be done in acute chest pain other than the guideline writers have to finally concede that it is a good test and it should be a class 1 indication. We literally have 6 randomized trials already performed. We don't need number 7 to push us over the top. That's not the definition of class 1. So I think that that will change in the near future. It was rumored that we were going to have new guidelines at AHA or ACC. Obviously, that hasn't happened yet, but I think we will start seeing new guidelines coming out, and hopefully they will start adhering to their own rules and giving us the class 1 indication that is indicated for acute chest pain and for stable chest pain. We have 2 randomized trials, at least large randomized trials. We have 4 total. Crescent and CAP were also randomized trials, but we have 2, Scott Hart and Promise, in stable chest pain that show superiority or similarity to functional testing. And if functional testing is class 1, CT angiography should be class 1 as well. Calcium scoring, I think we're going to be stuck at class 2 for a little while until, hopefully, there are 2 trials in Europe that are ongoing, calcium score versus standard of care. They're both large-scale trials. And if those trials are positive, I think we can move to a class 1 indication for calcium scoring. But I think we're going to need one of those trials to hit before we can move to class 1 for calcium scoring.
So one final question from me, Matt, is now the needle and prevention is moving more into the younger individuals. What testing would you do in that less than 40 years of? You still consider calcium testing? Are there special areas where you may start thinking about CT angiogram? What do we need to do to try to establish some of the roles of CT in this space?
Right. So I'd say calcium scoring in selected patients under the age of 40, patients with familial hyperlipidemia, patients with diabetes, early onset type 2 diabetes, patients with really bad family histories may still be fruitful. And certainly if you find calcium, even a little bit, Jeff Carr in the Cardia study, starting at age 32, found impressive risk stratification abilities of coronary calcium. However, most patients are not in those categories. And therefore, I would say if you have somebody with even very atypical symptoms, I would have a low threshold for CT angiography. If they're totally asymptomatic, maybe 3D carotid imaging, where we're seeing more data come out from Val Fuster's group, high-risk plaque cohorts that are looking at 3D carotid imaging in the young. And I think in the young, there may be some advantage to looking at the carotid. In general, carotid imaging is not as good as calcium scoring. We know that from a dozen or more trials. But in the young, it may have an advantage of no radiation and the ability to at least see the carotid vascular beds with pretty high resolution.
Well, Matt, thank you so much for your lecture and engaging discussion, and more importantly, joining us so early in the morning, 6 a.m. from LA. Wishing you all the best, be safe, and sending our regards to everyone at your institution. Thank you so much again.
Thank you as well.
Take care.